Let me say a good morning or good afternoon or good evening to everyone that has joined us today. My name is Falake Olayinka and I'm the immunization team leader at USID in the Global Health Bureau. I also serve as the lead technical advisor for the COVID-19 vaccines access and delivery initiative within the Global Health Bureau at USID. So thank you for taking the time to join us this morning or this afternoon or evening, depending on where you are in the world, for a conversation, a fireside chat, where we as a global health community can come together on identifying and reaching zero dose children around the world. This is a timely and very important topic. As we wrap up this week, World Immunization Week, and it is my privilege and honor to moderate today's conversation with several immunization experts from our USID's Momentum Suite of Awards. And it is our flagship implementing a range of interventions and programs across maternal child health, immunization, family planning, reproductive health. I am excited to discuss with the colleagues today. Before introducing our experts and starting our conversation, I want to share just a little bit around zero dose. When we say zero dose, we are referring to all those who have not received a single dose of the vaccines that prevent life-threatening and debilitating diseases. And these include particularly the first doses, BCG, hepatitis B, oral polio vaccines, but also really includes diphtheria, tetanus, and pertussis as a major benchmark. The first dose of DPT or penta-containing vaccines as a benchmark. Today we have estimated 17 million children who did not receive a single dose of vaccine in 2020. This has been affected by the COVID-19 pandemic and has increased by up to 3.7 million more in 2020 compared to 2019. Sadly, zero-dose children are more likely to suffer from sickness and die from them. But they also face social, systemic, economic disadvantages and barriers in many instances, and live in communities that struggle to access even the basic health services. For those of you just tuning in, welcome, whether you're on LinkedIn, Twitter, Facebook, or YouTube. You are most welcome. We look forward to your questions and comments and a very lively conversation today. Please be sure to ask in the chat, your questions in the chat, to have them answered live. You can also tweet with hashtag #AllThingsZeroDose. This is all one word. And thank you so much. I am honored to introduce our discussants for today. Let me first start by introducing Dr. Chizoba Wanadi, the Director for Immunization on Momentum Country and Global Leadership, MCGL. Welcome, Chizoba. I'd like to now turn to Dr. Christopher Morgan, who is the Senior Technical Advisor for Immunization on Momentum Private Healthcare Delivery and Momentum Country Global Leadership. Chris also plays several important roles in global advisory committees, such as the chair of a WHO regional text group. I'd like to turn to Jessica Shearer, Dr. Jessica Shearer, is the monitoring, evaluation, and learning lead on momentum, routine immunization, transformation, and equity. Dr. Shearer leads the project's approach to identifying and monitoring zero dose and under immunized children, bringing her vast experience and innovative methodologies. Welcome, Jessica. I'd like to now turn to Laura Shimp. Laura Shimp is the Senior Immunization Advisor on Momentum Routine Immunization Transformation and Equity, as well as Momentum Integrated Health Resilience Project. Laura Shimp is also the Director of the International Immunization Center at John Snow. Laura, we're so delighted to have you here and your immense wealth of expertise and experience. Thank you.
Thanks for having me.
Thank you all for joining us today and sharing your perspectives with us. Before we get started, I want to mention USAID's commitment to immunizing all around the globe and ensuring no one is left behind. Commitment to reaching zero dose children. And through our flagship award, which is the Momentum Suites, it really builds on many global strategies and policies, including the Immunization Agenda 2030, Gavi's framework for reducing the number of children who have never been immunized. The project's primary questions include and continue to be relevant around reaching zero dose, but also at the moment, especially given the effects of the COVID-19 pandemic on immunization around the globe. So a couple of questions that we're going to delve into. Where and who are the zero dose children and missed communities? Why are they being missed? Why do families live in underserved communities and continue to feel and think about basic access issues? Why is it so pervasive? What do they wish were different about immunization services? And then let's also think and discuss about what are some of the most feasible, cost-effective strategies for reaching zero dose children and under immunized. You all bring extensive experience in this field, and we really are looking forward to your discussions, your perspectives, and your views in tackling these issues. Now, before I turn to my first discussant today, I want to be sure you have your coffee or your tea, your marshmallows or whatever is appropriate in your context. You're feeling cozy and warm. I'm all warmed up here. And before I do that, I just want to remind us that we're really looking at a trajectory for a long life for all children. From the day they're born to have the opportunity to not just survive, but thrive and have a long life. So this is a really critical starting point. And so I just wanted to underscore that. And with that, let's hear from Dr. Chizoba Wanodi. And the question I want to put to you, first of all, is the zero dose phenomenon a new problem? And what are some of the historical trends over time around zero dose? So if you could share with us from this perspective, why now? What is different about this present moment from your vantage point and from your expertise looking at this over many years? Chizoba, over to you.
Thank you very much, Folake. It's a pleasure to be here. Greetings to everyone watching. So, Folake, to answer your question, is zero dose phenomenon a new problem? You have defined what it is. And I would say, no, it's not a new problem. We have had this problem for quite some time, since the 80s, when WHO started recording immunization coverage data. What we see from WHO data is that the there has been a general improvement in the zero dose problem. So, for example, in the 80s, in 1980, 70% of children were zero dose, according to the WHO data. That is, there were more zero dose children than children who were vaccinated. But this declined sharply, and you would say it's an improvement. It improved from 70% in 1980 to down to 12% in 1990. So in the 80s, we made a huge amount of progress on reducing zero dose. And then from 1990, it went up and down, and peaked at about 17% in the year 2000. That this is global coverage, global prevalence now. And then you mentioned it, by 2019, it went down to about 13%. Okay, but what has happened is it went down to 10%. But what has happened is that in the last 2 years, as a result of COVID, all the progress we made in the 2000s and in the 2000s has been regressed. So COVID took us back 15 years. According to recent data, the most recent data, 13% of children are zero dose in the world, but there is variability. It's worse in Africa. So in Africa, there are 2 times more zero dose. The rate of zero dose is 2 times more in Africa compared to the rest of the world, and 7 times more compared to Europe. So it's not a new problem. We've made progress, tremendous progress in the previous decades, but in the last decade, progress has stagnated, and COVID made it worse. So we care about zero dose because it's really a reflection of our failure to reach vulnerable children and vulnerable communities with services. So it's a social justice issue. It means that we as a government, we as a community are not doing what we ought to do to protect children, given that we know that vaccines are tremendously beneficial. We know that vaccines save lives. We know that vaccines save cost for countries, right? When kids are not sick, then their parents will not pay for healthcare. If kids are not sick, then the government will not pay for healthcare. So vaccines not only save lives, they also save money. And there are studies from Harvard that shows that children who are vaccinated are more likely to do better in school. So their educational attainment is much higher than children who are not vaccinated. And then and we know from, just even from general knowledge that educated people do better in life. So it's a social justice issue that the global community has come to recognize that we need to do something about it. And Folake, you talked about the IA 2030 and Gavi using equity as an organizing principle to say that we must leave no one behind. So now,
so Chizoba, I'm gonna come in here because you're really bringing a lot of passion to this topic, and I wanted to pursue the issue of the variability in terms of where exactly are these zero dose children? Who are they? Do we have information that helps us understand who they are? Where are they? And what are the risk factors? So Chizoba, I'm going to move on to Jessica, and I'm sure during the discussion, I'm going to follow that thread you had about a social justice issue. So thank you for bringing that perspectives as well. Jessica, do you want to weigh in here for a moment?
Yes, thanks, Folake. Happy to. And thank you, Chizoba, for bringing this up as a social justice issue, which it truly, truly is. And so, for example, Folake, you asked, what do we know about who these children are, where they live? We know that over 2/3 of zero-dose children live below the poverty line. So they come from families and communities that are extremely impoverished. We also know that over 50% of zero-dose children tend to live in 3 types of contexts. So very rural, remote contexts, conflict-affected settings, and then urban environments. And you can start to imagine why in each of those contexts children would be missed or entire communities would be missed, right? But as you mentioned, Flake, and Chizoba, with COVID, we see even more zero-dose children. Those communities I mentioned and the poorest and most vulnerable families tend to be now affected the most also with COVID and with the effects of COVID. But we see zero-dose children sprinkled everywhere now. And gender barriers are another huge driver, huge factor of why children are zero-dose. And what we mean there is specifically barriers faced by their mothers most often in trying to access high quality, affordable health services. So on that point, talking about some of the barriers that families and communities and children and their mothers face. In our project, Momentum Routine Immunization Transformation and Equity, we really try to look at this through the eyes of the caregiver, through the eyes of the family and the communities, again, many of whom have been missed by not just immunization services, but by all health services. So I'm a parent, and I know many of us probably are here, and you can imagine that you can kind of start to empathize with mothers living in these contexts and thinking about all of the barriers and all of the challenges that they have to surmount to get their child vaccinated, right? And if there's 1 or 2 of these, maybe they can surmount those. But as they add up, it becomes harder and harder and harder. So for example, distance to the nearest health facility, the cost of getting there, whether that's the cost of taking time off of work or the cost of transportation, or even having to pay some fees for services, having other children that need childcare, needing to make decisions together with other family members. And then, of course, there are also...
Jessica, I'm going to just come in. You said the cost, but isn't vaccination free in many of these contexts? Say more about the cost. What do you mean by that?
Yeah, great question, Flake. Well, so if you, for example, we spoke to women in DRC and mothers of zero-dose children to try to understand from their perspective, why can't they access services? And first of all, we learned that many of them are working, for example, in informal market settings. They can't take time off of work, right? So there's that cost side. But then we also found that they were being charged fees for services at the health facility. And most often these were fees for immunization cards, and these are illicit. So immunization services should be free to everyone, but sometimes they are not. And oftentimes when we explore the root causes of that, that's because the health facilities themselves do not have enough funding. The staff are not being paid. So people are doing what they need to do to make things run. But for these most poor women, they said, we can't afford even the small, it's the equivalent of maybe $2 or $5 US dollars. They said, we can't pay that. It's a huge barrier to us getting our kids vaccinated, even though we want them to be vaccinated.
So really having the awareness and knowing about the benefits of vaccination is not enough. There are barriers that they face in their daily lives, and these are people that live below the poverty line and then the lower socioeconomic wealth quintiles. And that really, helps me to wonder what kind of experience have we brought to solving some of these problems and challenges that you talk about, Jessica? And what is the evidence in terms of reaching what in previous times we used to be called unvaccinated, unimmunized, which we're really capturing today as zero dose? And how do we overcome these barriers? I'd love to draw from some of your experiences. And with that, let me turn to Chris to come in here and share some of your thoughts and perspectives, especially some of the things that Jessica raised that are real barriers in reaching zero dose. Thanks so much, Jessica. Over to you, Chris.
Yeah, thank you, Falaki and Jessica. That's It's great to be here. It was really about 10 years ago, I think, that another momentum predecessor called MCHIP, which was a USAID-funded health program, had a really good hard look at, in the grey literature and the published literature, what were the reasons why children were either not getting vaccinated at all or under-vaccinated. And when they analysed it, about half of the reasons related to the immunisation program and system itself. So supplies not getting there or the services not being at the right point in the right time. And I think that supply service delivery part of the equation really needs to be put all the time alongside the things Jessica mentioned around distance and the cost maybe of transport or getting time off work. Because what came out of that research about 10 years ago was this concept of the need to tailor immunisation services particularly closely to the populations that were not getting reached. I do remember one high-level WHO meeting in 2013 where a program was presented to examine the unvaccinated child, the child that had not been vaccinated at all. And they called it the UNVAC Toolkit. And one of our pieces of advice at the time was they needed some branding advice and maybe a change of name. And I think one thing that is new now, which has really helped move this along, is this concept of the zero-dose child as a real key focus. Because I think over the last 10 years, we've tended to look at both children who didn't get any vaccinations and children that got some but not enough as one consolidated group. And we're aiming to look at the barriers for both groups. But I think this laser focus on the zero dose, the child who's not received any service at all, and what is going on for them and their family is a really helpful advance to take us forward.
Thank you so much, Chris. And I want to link what Jessica talked about in terms of where are these zero dose. And you mentioned that you can, oftentimes within conflicts, fragile settings, also in low socioeconomic communities, urban slums, remote, hard to reach. And Chris, you really brought in the element that we need to be able to tailor the programs, especially looking at zero dose distinct from the broader pool of under-immunized. And thank you for bringing these elements out. For those of you who are just joining us and streaming into this conversation, you're most welcome. Don't forget to send in your questions through the chat line, or you can tweet them with hashtag #AllThingsZeroDose, all one word. So welcome again. So I just started to, look at the different contexts in which we find zero dose. I'm so pleased that we have Laura Shimp here, who really brings perspectives on a number of different contexts. But I want to speak a little bit in terms of the added challenges in fragile and conflict settings and the shocks that are rampant within these contexts. So Laura, which immunization approaches are resonating most in terms of reaching zero dose and under-vaccinated in diverse populations that the Momentum Integrated Health Resilience, MIHR, is supporting? And you work on this on a regular basis. So we'd love to hear from you and your thoughts in this type of settings and context. And you're welcome to share thoughts on other comments that have come up before, but why don't we start here with you, Laura?
Thanks, Falaki, and thanks to everyone for joining and to the other panelists. Yeah, one thing we've seen over the years with immunization, and we certainly have seen this in the COVID-19 context, is that fragility can be episodic, and it can also affect otherwise stable systems. So in Momentum Integrated Health Resilience, we've been looking at that humanitarian to more stable system nexus, and how do we move from crisis or help programs to address those shocks, like you mentioned, Falaki, and Jessica very nicely outlined where we see some of the unvaccinated and the fragile. But fragility can be episodic, and it can be emergency, as we've seen with earthquakes in Haiti, as we see with volcanic eruption in eastern DR Congo. But it can also be endemic, particularly for mobile populations that aren't going to one facility, or for areas that have high insecurity, such as the urban areas of Port-au-Prince, or in the northern parts of many of our West African countries where we've had insecurity. And what really we're finding is most important to reach all services, so primary healthcare and preventive services, not just immunization. I would categorize it in 6 C's. First off, coordination and collaboration as part of that. Really interagency, involving communities and civil society. And that leads me to the second one, which is community-centered. We really need communities to be actively part of our committees and our coordination, because they know best and have the trust of the population that they're working with or that they're part of. Then that leads me to the third one, which is confidence, and that idea of really being able to understand the system, the health provision, so in this case, vaccination and immunization. So notice I'm not saying hesitancy, I'm saying confidence. Do they have what they need to go to the service and to find that service usable? And that then gets into the context, which is the next C. Is it context specific to their needs, and can they access it the way they need to? And then, of course, the other two are capacity. Is the system, the staff, the supply, is that there for them when they need it and reliably? And then, of course, cost effectiveness. We know in fragile settings, it's not going to follow the same formulaic system, one vaccination session per week or one outreach session per month. We don't always have that ability in fragile settings. So what we need to find out sometimes is how to do this periodically, using periodic intensification of routine immunization, for example, to find these communities and plan with them at times that are accessible to them. Through some of the work we've done with rural remote communities via the UIFHS project, for example, in Ethiopia, we've seen and really worked with quality improvement practices with these mobile communities across Ethiopia. So really trying to understand how best to reach them and what are the best characteristics of the program for their needs. We see this also in Gao and Timbuktu now with Momentum Integrated Health Resilience. These are mobile populations, but also with fragile settings because of the insecurity, where they're following their herds and they're actively mobile. But they need to also know that when they come to a service, that service is going to be available, and they can't guarantee that they'll be at that service the day that they need to be there, or that service will be open if there's episodic insecurity. So that's where that context-specific community planning is so important. And then, of course, the information that goes along with that to know where and when they can go, and to have that communication, which can be everything from a community mobilizer, the importance of relais communautaire that we see in DR Congo, who have to be actively part of committees and health teams, not just for a campaign, but on a day-to-day basis to help with that planning. And for Tanzania, for example, the Health Facility Governing Council that exists in every health facility, having a community representative active in that, who then understands the local resource needs and can help top off that little piece that's going to make sure the service happens, like fuel for the motorcycle for the outreach or for the outboard motor, or that they might need a little bit of money for per diem for a mobile service. And those services, mobile services, particularly for hard to reach or marginalized communities who live in fragile settings, they're going to cost more than a normal facility operational program in a functional health system. So that we also have to adjust in that cost effectiveness for how to reach the populations and when is best to reach them. Thanks.
Thanks so much, Laura. You talk about the 6 C's, which is really very elegantly described. And I really wonder, just a quick follow-up question, that, you've talked about the need for this paradigm shift in the fragile settings, that things are unpredictable. And we need to find ways that can be appropriate to this kind of context. So let's go to one of your C's with looking at the community at the center, and what does this look like in such a context in terms of civil society or community organizations? Could you describe how is this different from a non-fragile or conflict setting, for example? Help us understand that a little bit more.
Yeah, thanks. I think the idea of community-centered and really having civil society organizations in many forms as part of that planning. In DR Congo, for example, we have seen in the interagency coordinating committees over the years, you have SANRU, Santé Rurale, which is a group of health civil society groups and organizations. You have the ACC and CRS and Catholic, BDOM, different religious institutions that also work across the country and provide health services. It's critical not only to have them at facility level and make sure they're resourced to provide that assistance, be it service delivery in the sense of organizing sessions or being able to do mobilization of populations to understand where and when to go. And, as Jessica was talking about with some of the maternal education, we can get civil society groups, as we've seen with traditional birth attendants, for example, in northern Nigeria, to provide information at delivery so that mothers understand what vaccines they should be receiving, get a vaccination card, hopefully in their hands, that then gives them reminders of where and when to go for services, and then be able to help with that interface between the facility and the community. And also then even at national level, the role of Rotary, for example, as part of the ICC in DR Congo and the other civil society groups that I mentioned, it's fundamental that they be part of those conversations, not invited later, but actively part of the initial conversation and the resourcing. What we often see, and I applaud Gavi, the Global Alliance for Vaccines and Immunization, for the efforts it's doing now to increase resourcing to civil society. Hopefully that will play out to be an increased, and this is what I mean by the paradigm shift. We shouldn't be giving small percentages to them as a sort of fill in gaps. We should be having them at the top of the planning cycle with the resources they need to help us find those unvaccinated zero dose, and then help find those same children for their next dose of rotavirus, for their next dose of pneumococcal virus, through measles second dose, not just for one antigen or one campaign. And on top of that, we also really, really need to be able to have civil society understand and be engaged as partners on the planning of the services to make sure that that they meet the needs and access of the populations that they're with.
Thanks so much, Laura. On the points, the excellent points that you've made in terms of partnerships with civil society, with community partners and communities themselves in the different roles that they could play. It really, brings to the forefront some of the core investments that USAID has made over time, and that has been partnering with communities and really ensuring that they are engaged in different ways in their development journeys in different contexts. But I know Chizoba has had, quite some experience in terms of expanding partnerships to tackle zero dose problem. How can this be done in a holistic way? I think Laura started to describe some of the different ways, but Chizoba, I want to turn to you right now and hear your perspectives in terms of can we do better? How can we do this in a holistic way? And share with us some of the tools and strategies and new ways. We want to hear about the innovations in terms of addressing this zero dose challenge. So Chizoba, please feel free to weigh into this conversation.
Yeah, thanks, Falake. Laura really set the stage. I think what we need to recognize is that truly government cannot do it alone, because if we've been stagnant on the issue of zero dose for the past decades, we need to think differently, we need to act differently, and we need to bring new people on board. And so civil society, Laura has mentioned, that's certainly true. Also private sector. You find that in many of these communities, you find there's no health center there, but there is a there's a patent medicine vendor. So those private health providers should also be part of the equation. And then religious organizations, many countries, particularly the countries where you have high zero dose, majority of their population attend one faith group or the other. So they go to church on Sunday or go to mosque on Friday, and that is a potential point of access. So we really need to bring in the faith-based organization. So one thing MCGL has done in trying to help move this area forward is to put out some guidance, because it's not enough to say engage CSOs. How do you do that, right? There has to be an intentional way to do it. You have to identify the comparative advantages of civil society organizations or faith-based organizations. So what we've done in MCGL is we've supported the CSO platform, the Gavi CSO platform, as well as the Gavi Secretariat, to come up with a civil society engagement framework. So this spells out for governments and for partners how best you can bring CSOs on board. So how can you engage CSOs so that you can deliver together? And that's a new tool that's come out, and it's going to be socialized and disseminated through various forums. The other one I want to point out is another work that MCGL has done, Momentum Country and Global Leadership has done, is to bring together promising practices and how faith-based organizations and faith leaders have been engaged in immunization and how they can be, leveraged and partnered with to improve the problem of zero dose. So that tool and that resource is available on the Momentum website. It gives specific examples. For example, like I mentioned before, most people attend a church or a mosque. And these religious institutions can not only provide information, they can also be places where services are delivered, where outreaches can be held. Those kinds of examples are in that tool. Then the last tool I want to mention is a new tool that's been tried in Nigeria. It's called the Z-Drop tool. That's the Zero Drop Operational Plan. What it does is enhance the existing micro-planning process, because you, as a national manager or sub-national manager, you need to know where those zero dose children are, right? As we're addressing the zero dose problem, we need to be laser focused. So we can't do everything everywhere at the same time. If we need to move on zero dose, we have to first identify where they are. So this Z-Drop tool does that and more. It's the one-stop shop where you can see for your district or for your sub-district or for your facility where the zero dose children are. It's also where you can gather the targeted solutions that you have co-created with the communities. And then it's also where you can estimate the resources that you need to address and reach the zero dose children. So this is still brand new, and it's it was designed as a necessity because of the gaps that we're seeing. So we're really excited in MCGL to try to test this out to see how it's going to work. But it has great promise to help managers really focus and then consolidate all their plans for reaching zero dose children.
Thank you very much, Chizoba, and also bringing some of the innovations and innovative approaches and tools that are coming into trying to find approaches and effective ways to really reach zero dose children. I'm going to turn to the chat just a moment, and there are a couple of questions that are coming through that I want us, to speak to. So we have questions coming in. John Barrazo, thank you so much for your question. And the questions you have here, can we move beyond the health sector to address some of the social, cultural, political factors that may play a role in why some children are being missed. I think this is very important for us to address. So I'm going to put that out there. And maybe, I don't know who we want to speak to that, but maybe Laura, we can start with you, Laura, and go on to other people and other questions. Laura.
Thanks, and thanks, John, and those contributing questions. It's such an important question. And one thing we're seeing with Momentum Integrated Health Resilience, although this is not new, I mentioned Gao and Timbuktu earlier. Many years ago, USAID was providing support for some NGOs working with nomadic populations and working with the agricultural sector, zoonotic areas, and those working with animal husbandry. That's also critical for these populations, as we've seen with rural remote in Ethiopia, so that they're getting wraparound services for their herds as well as their people. And that type of collaboration is critical, as we're also seeing. We talk about zero dose in the sense of Penta 1 or DPT containing vaccine 1, but we've seen a lot of zero dose with HPV vaccination. And for that, we really need to reach out, as I said, in coordination with groups like adolescent youth organizations. Partners, Girl Effect has been a key partner in the HPV world, where they understand how to reach these populations with services beyond just health, but also well-being, counseling for mental issues, or just for development needs. So I think those are areas that we really need to be looking out at. And we also should not take all vaccines as one, fell swoop. We know that zero dose, not getting DPT, we may be able to get them, but then they're not getting their rotavirus vaccine. We've seen a big challenge with rotavirus vaccine uptake in DR Congo because it was introduced right before the pandemic. So just because one might be zero dose for one vaccine or maybe hesitant with COVID vaccination, that doesn't mean they won't accept other services. And that's really where that dialogue with caregivers, with health workers needs to be continually fostered, so that we really have that collaborative, good service experience, and health workers who feel supported, not only to do their job of vaccination, but also to communicate, to build trust and confidence, and to really meet the populations with accessible services that wrap around, meet everyone's needs.
Thank you so much, Laura. I want to draw in Jessica a little bit here in terms of, what are, beyond the health sector, what are some of those broader social, cultural, political factors? Do they play a role? Do political factors play a role?
They certainly do, Falake. They play a really important role, first in terms of ensuring that immunization services and all primary healthcare and social services are adequately financed, but then ensuring that they get to vulnerable and socially marginalized, socially excluded communities. So there certainly is a big political element there. And so because of that, people have also mentioned that I think Chizoba said this earlier, we have to work with government, we have to work with civil society. So essentially, we also have to work with other non-traditional partners. And we're seeing in some of the countries where we're working that we're having tremendous success working with non-traditional partners. Faith-based leaders have been mentioned. Sometimes those are the people that communities look the most towards, trust the most, and they can really make a difference quite quickly in outcomes. We're finding a bit faster than some of the long-term, governance strengthening initiatives that also need to happen to strengthen the health system overall and the social systems in countries. So it definitely takes a multi-pronged approach to all those things. Thanks.
Thanks so much, Jessica. Earlier in your statements, you talked about gender as one of those critical factors that have to be really integrated into all aspects of the programs, and identifying and overcoming those gender-related barriers. So thank you for bringing some of those factors up. And we can.
Can I also say, just to jump in there, I think it's been really interesting through some of our work that when we start asking communities and healthcare workers why children are zero dose, and we start probing a little bit on gender, do you think there are any gender barriers faced by their mothers, their caregivers? The first answer is always no, right? But when you bring them together, when you ask the mothers about the barriers that they face and they start to explain their challenges, it's very eye-opening for everyone else who's listening. And so we've facilitated community-based workshops where we have those moms talk about, the challenges that they face and what they would want to see in immunization services. And then we ask the other stakeholders, what can you do? How can you act here? And everyone can act, particularly at the community level. So it's just been really interesting to see actually how we can talk about and start to address gender barriers faster than you might anticipate.
Thanks so much, Jessica. There's another question here that I want to get to very quickly, and this is looking at COVID-19, and that really revealed issues around vaccine confidence. Let's put it that way. And so this is real in many settings, both high income as well as lower income. And COVID-19 really brought this to the fore. So do we have a sense of how much this is contributing to zero dose, particularly in low income settings?
If I may come in here.
Yes, please.
Yeah, I was looking at the data recently, and yes, COVID-19 made worse the problem of zero dose. But if you look at Africa, the problem, the regression in zero dose issue was actually lower in Africa. So Africa did a little bit better than other regions, even though overall Africa has a bigger zero dose problem. So one of the reasons, I think the major driver for the increase in zero dose is really the disruption of the immunization system from the COVID pandemic. As we know, when the COVID pandemic hit, there was a lot of confusion. There was a lot of fear. Parents were afraid to take their children for vaccination, not because of hesitancy per se, but because they were scared of getting COVID in the facilities. And then the lockdowns, the movement restrictions, and all that happened that disrupted the health system. So the zero dose problem in Africa is largely driven by the supply side issues and the access issues more than the hesitancy issues. So I think that's where we really need to place our emphasis on how do we identify these children? How do we take services to them, services that fit their lifestyle, that fit their needs? If we take services to them, the majority of them will accept it. And then hesitancy really that we saw with COVID is mostly around the COVID vaccination itself. But there is a risk that it could spill over into routine immunizations. That's where we also need to maintain our vigilance in addressing the hesitancy. Thank you.
Thanks. I see there seems to be a lot of nodding and agreement with what Chizoba said. So Jessica, do you want to come in for a minute here? And then I want to pivot to another question. Go ahead.
I just want to agree with Chizoba so much. And again, when you talk to mothers, when you interview mothers, it's not so much a lack of confidence in the vaccine, but a lack of trust in the health system, which has not served them well in the past, right? And so I think we need to really reframe, maybe instead of vaccine hesitancy, we're reframing it towards vaccine confidence, which is helpful, but even confidence and trust in the health system, which is really, really critical. So thanks for those points, Chizoba.
Okay. So I'm going to go to another question because the questions are coming in through the chat. Thank you all for sending your questions. But how do we get sustained community or civil society engagement for routine immunization without financial incentives? I think that's a critical piece here. And maybe I'm going to call on Laura, who wants to weigh in on that, and Chris. Okay. So
sure.
we'll have Laura and then Chris, feel free to come in right after.
Thanks so much. And I think it's such an important question because community members are there. We all live in a community, but the community we live in may not be where we go for services. So part of it is understanding the communities within communities, those networks, and how to build on those networks that already exist. And I think, India is a great example of how they have had political will, how they have worked with communities. They have established the ASHA program, which has incentive-based activities, but it's not the government that's paying those incentives. It's the Panjanti Raj Institutes, the community organizations that are helping to resource that and make sure that those ASHAs, along with Anganwadi workers who provide nutrition and food security services, as well as the health system through the auxiliary nurse midwives, all of them work together to reach populations and identify missed children or children who are due for services. And we have seen through birth dose vaccination and working with delivery services, thousands and thousands of children in Uttar Pradesh being picked up just by linking a few key services like ASHAs and delivery services with vaccination services. So it's feasible, but that political commitment is very important. And also, as we said earlier, acknowledging that civil society, I always joke in French, bonne volonté, volunteerism only goes so far. I mean, how many hours do we each volunteer a week in our community? And we're all paid professionals, so we have to acknowledge that there is an opportunity cost that comes with community engagement and with that volunteerism and celebrate that success. Madagascar has a history of a champion community approach that celebrates success of the community in wraparound health services. And I think there's been great learning from all over Madagascar and how that's been done to really build trust with the political, the health, the agricultural, and the services.
Thanks, Laura. I'm going to invite Chris to come in on that. But Chris, I also want you to take Sonali's question here around the engagement of private sector in reaching zero dose. So Chris, over to you.
Yeah, thanks. I really appreciate Sonali's contributions earlier in the comments. And especially from that India perspective where the political commitment has been so great, both across COVID and other vaccination. And she really makes two critical points. One is that we need to be clear about which type of zero dose we're talking about, because in India, Afghanistan, a few places, they're still using the term zero dose for vaccination given at birth. But what we're really talking about, zero dose defined as the children who miss out on any of the essential vaccines, often defined as the children who miss out on the first dose of DTP-containing vaccine. But Sonali makes a really important point that if we're thinking about services tailored to the preferences and what's acceptable to families, like Chisba and Jessica were saying, sometimes that is in the private sector, not the government sector, whether it's the non-profit NGO, faith-based private sector, or the for-profit private healthcare providers. And given, like you said earlier, immunization is supposed to be free, what's the incentive, like Tosin says, for them to be involved? So under Momentum Private Healthcare Delivery, one of the things we're doing is looking back at the history over the last 20 years of private sector involvement in immunization generally, but really trying to focus on this key point of what's the motivation for non-government providers to get involved in immunization? How can we build on that motivation, even if there's not a financial incentive, and to really bring them in a much more coordinated fashion, whether they're ex-mission hospitals or whether they're private providers or small private clinics. There are reasons to get them into immunization in a way that will strengthen the system. And often the non-government provider is in the place where the government services don't reach, maybe particularly in fragile or conflict-affected areas. And so making sure they've got access to vaccines, access to policies, access to good practice is essential. And then the second thing, apart from that look back at the evidence that we're doing, is to try and do some case studies on how non-government providers have been roped into the COVID vaccination rollout response, particularly in resource-constrained settings. And with those new partners that have been ramped up quickly to help COVID vaccination get out, which of them are likely to be good new partners for the long term to help programs? We don't know which ones are just appropriate for the emergency and which ones will help in the long term, but we're trying to do some case studies to find that out. And anybody on the call that's got a good example of new private partners being brought into immunisation through COVID, we'd love to hear from you. Thanks.
Thank you very much, Chris. And we touched on some of the impact of COVID-19 pandemic that's affected a number of zero dose, and this has been seen in all regions and to varying extents. And we know in the recent SAGE meeting there was really a focus on this issue in terms of doing better to ensure recovery, catch up, and also strengthening the routine system. So I'm going to give each of you 30 seconds each if you want to say something about that. What more needs to be done, especially now in the face of COVID vaccinations, and what is happening across the country. So I'm going to, and this is your wrap up. So weigh in on that, and we'll be ending the session very soon. So Chizoba, 30 seconds.
Right. Okay. So I think COVID has presented both challenges and opportunities, but let's focus on the opportunities. There is money coming into the system. There are new innovations with data systems. There is mass vaccination going on. Let's use that opportunity, that money, that momentum to provide family-oriented services and reach zero dose children. So COVID is an opportunity for us.
Okay, thank you very much, Chizoba. Jessica?
Well said, Chizoba. I think we need to work really hard. We need to do better right now to identify and catch the children who were missed during COVID. We have so many zero dose children right now, and we need to invest, taking advantage of the resources that Chizoba mentioned. We need to invest now in finding those children before it's too late.
I'm going to pivot the question a little bit. Again, feel free to speak to the broader issues around zero dose. So Laura, over to you.
Yeah, Falake, and thanks again. I think, to your point about the SAGE recommendation, I mean, obviously we're in the Immunization Agenda 2030 10-year plan, really trying to look at life course. So vaccination not just being about infants to 2 years of age, but actually HPV at pre-adolescence, getting tetanus into older children, and then, of course, through life course with COVID vaccination. So I think refocusing on that, but also not losing sight. There's a lot on measurement and trying to identify, but we need to reach these populations. We need preventive health programs to be resourced over the long term. It's about people, not percentages. It's names, not numbers. If we're just going to say zero dose as an amalgamation, that's not going to find the individual child in an urban poor settlement. We need to find those children, or we need to find those high risk immunocompromised in elderly populations for COVID, and getting into a little bit of that granularity and resourcing that over the long term will be very critical.
Thanks so much, Laura. Chris?
Yeah, I think I agree with what the people previously have said, particularly Laura's last point. I think one extra thing that COVID has taught us is that to roll out vaccinations quickly, new partnerships have been formed. For example, with HIV programs that are good at reaching adults with preventive care. And it's incumbent on us, if we really want to reach the children that are missing out, the zero dose children, to foster those new partnerships that COVID has stimulated with HIV programs, malaria programs, maternal child health programs in new ways, even going beyond the health sector to non-traditional partners, and learn from those partnerships that have been rapidly stood up for the emergency, how to use them to sustain immunisation and increase its reach to zero dose children for the long term.
I really want to thank all of you for your excellent contributions around our fireside today. I also want to thank the audience and the participants who have joined us. Thank you all, and really just appreciating the work that you do around the globe, and also in terms of reaching zero dose, the innovation you bring, the local solutions, the communities, and really addressing and helping to remove those different barriers in different contexts. So thank you all very much, and have a wonderful rest of your day, evening, or morning. Thank you.
Thank you.
Thank you, Falake.